Hello everyone, welcome to SAK Anesthesia. Before we start, don't forget to like, share, and subscribe to our channel. In this lecture, we're going to talk about anesthesia for ophthalmic surgery. Techniques of anesthesia. There are two main types of anesthetic technique are available. Number 1, kinetic anesthesia, which includes topical anesthesia, facial nerve block, subconjunctival injection, intracameral injection of a substance into the eye cavities. Number 2, akinetic anesthesia, needle injection of local anesthesia, which includes Retrobulbar block, also known as intraconal block, Peribulbar block, also known as extraconal block, Sub-Tenon block, also known as parabulbar block, and general anesthesia. Topical anesthesia. Advantages: cost-effective, immediate visual recovery, avoidance of complication, globe rupture, nerve damage, quick, non-invasive, well tolerated by patients. Disadvantages: no akinesia, not suitable for extended surgery. Well-informed and motivated patient is required. Careful patient selection. Cooperative, not distressed. Straightforward surgery. Must be able to lie supine and still, not claustrophobic. Sedation. Anesthesiologist should be standby. Phacoemulsification. Phacoemulsification is a modern cataract surgery in which the eye's internal lens is emulsified with an ultrasonic handpiece and aspirated from the eye. Aspirated fluids are replaced with irrigation of balanced salt solution to maintain the interior chamber. Procedure: administered 20 to 30 minutes before surgery, 2 to 3 drops every 5 minutes. Cornea is avascular. Once absorbed, local anesthetic remains for about 30 minutes. Could be supplemented by incremental injection. Challenging operating conditions. Because of no akinesia. Uses of topical anesthesia. It is used for manipulation of superficial cornea and conjunctiva, for phacoemulsification in cooperative patient, and prior to regional blocks. Adverse effect of topical anesthesia, which could be epithelial and endothelial toxicity, allergy to drug, alteration of lacrimation, and surface keratopathy in which cornea could be damaged. Drugs for topical anesthesia: oxybuprocaine. Onset of action 6 to 20 seconds. Duration of action 15 minutes. Topical 0.4%. Lignocaine. Onset of action 5 to 10 seconds. Duration of action 10 to 35 minutes. Topical for percent. Proparacaine. Onset of action 15 to 30 seconds. Duration of action 15 to 20 minutes. Topical 0.5%. Amethicaine. Onset of action 10 to 25 seconds. Duration of action 10 to 20 minutes. Topical 0.5 to 1%. Facial block. The aim is blocking the action of orbicularis oculi muscle so that the patient cannot squeeze the eyelid during surgery. Use as an adjunct to retrobulbar block. There are 3 types of facial block. Number 1, Van Lint. Number 2, O'Brien. Number 3, Nadbath and Rehman. Van Lint method. Nerve block close to outer canthus. 1 centimeter below and behind the lateral canthus, the needle is directed toward the temporal fossa. Drugs is injected, then the needle turned medially and downwards toward the infraorbital foramina where local anesthetic is injected. O'Brien method. Paralysis of the facial nerve anterior to the condyloid process of the mandible. The needle is inserted directly to hit the bone and local anesthetic is injected. Nadbath and Rehman method. The facial nerve is blocked at the stylomastoid foramina. Peribulbar block. Most popular nowadays. The aim is the local anesthetic injected into peribulbar space. Spreads to lid and other spaces. Produces globe and orbicularis akinesia and anesthesia. Local anesthetic agents. Lignocaine to percent. Bupivacaine 0.75%. Along with hyaluronidase 5 to 7.5 international unit per ml. Hyaluronidase is a protein enzyme. It works by causing rapid spreading of injected fluid into the body, which increases the absorption of injected fluids. Adrenaline 1 ratio 200,000. Volume 3 milliliters approximately. Insertion point, conjunctival or transconjunctival. First insertion point is junction of medial to third and lateral 1/3 of lower lid adjacent and parallel to orbital floor. Second insertion point is upper lid at junction of medial 1/3 and lateral to third just inferomedial to supraorbital notch. Insert a 25 gauge to 0.5 cm needle mounted on a 10 ml syringe and pass slowly backward parallel to the globe. If the needle tip contact the bone, it is retraction slightly superiorly to follow the orbit floor. Needle entry can either be conjunctival, means transcutaneous, or transconjunctival. Position of patient, supine and in primary gaze. Use of peribulbar block, cataract, glaucoma, keratoplasty, vitreoretinal surgery, strabismus surgery. Advantages: less chance of globe injury, less chance of optic nerve damage. Disadvantages: pain, conjunctival chemosis, less akinesia than retrobulbar block, insufficient to abolish the vision completely. Larger volume of local anesthetic is needed. The sign of successful block is ptosis. Akinesia, inability to fully close the eye once open. Contraindication: axial length greater than 26 mm. Perforated eye, infected eye, inability to lie flat and still. Retrobulbar block. Retrobulbar block is also called intraconal block. The aim is injected in muscle cone to block ciliary nerve and ganglion. Third, fourth, and sixth cranial nerves. Provides akinesia and anesthesia of the globe. Position of patient, supine and in primary gaze. Site of injection, in the lower lid margin just above a point between medial to third and lateral 1/3 of lower orbital margin. Steeply angled and deeply placed. Low volume is required. Rapid akinesia and analgesia. May require separate facial nerve block for lid akinesia. Greater potential for complication. Direction of needle: backward, upwards, and medially towards apex of orbit. Volume: 2 to 4 milliliters usually. Needle: a 20 to gauge 3.5 centimeters long. Advantages: complete akinesia, dilatation of pupil, adequate and quicker anesthesia, minimal amount of agent required. Complications: 1. Retrobulbar hemorrhage. 2. Globe penetration. 3. Optic nerve sheath injury. 4. Optic nerve atrophy. 5. Decrease visual acuity. 6. Retinal vascular occlusion. 7. Brainstem anesthesia. 8. Convulsion. 9. Extraocular muscle palsy. 10. Trigeminal nerve block. 11. Oculocardiac reflex. 12. Respiratory arrest. Contraindication: bleeding disorder, risk of retrobulbar hemorrhage, extreme myopia, globe perforation. An open eye injury may cause expulsion of intraocular contents. Posterior staphyloma is an abnormal protrusion of the uveal tissue through a weak point in the eyeball. Poor training and experience. Peribulbar or Sub-Tenon block. Apply topical anesthesia, Medicaine 0.5% or proximethacane. The conjunctiva and retract the lower eyelid with the help of assistant or using a lid speculum. In the inferonasal quadrant, the conjunctiva is lifted. 5 to 7 millimeters from the limbus, a small incision is made in the conjunctiva with blunt-tipped Westcott scissors and then used to dissect inferno-nasally a plane between the sclera and Tenon's capsule. Blunt cannula or needle is inserted to post-subtenon space and 3 to 8 milliliters of local anesthetic is deposited. Cannula may be rigid, metal, or flexible, long 30 to millimeters, short 25 millimeters, and ultra-short 10 millimeters are used, bathing the nerves and muscles within the cone. Advantages: avoid vascular and optic nerve injury. Requires lower volume of anesthetics. Better anesthesia to iris and anterior segment. Disadvantages: subconjunctival hemorrhage, more postoperative morbidity. Complication: central retinal artery occlusion, Conjunctival hemorrhage, chemosis. Chemosis is the swelling or edema of the conjunctiva. Major sight and life-threatening complications. Number 1. Retrobulbar orbital hemorrhage. Incidence 0.07%. Signs and symptoms are rapid intraorbital and intraocular pressure elevation, rapid orbital swelling, increasing proptosis, displacement of an eye or other body part, marked pain, chemosis, vision down to poor perception or no perception of light, management, evaluation, indirect ophthalmoscopy for evidence of central retinal artery perfusion compromise, immediate medical treatment, lateral canthitomy to relieve IOP, orbital decompression, intravenous osmotic agents such as acetazolamide and mannitol. Number 2. Globe perforation. Occurs in exceptionally soft eye. Myopic eye is more prone. Retrobulbar anesthesia. Peribulbar anesthesia. Incidence of globe perforation is less than 0.01%. Sign and symptom. Marked pain during the delivery of local anesthesia. Hypotony, as low intraocular pressure, IOP, and occasionally is associated with decreased vision. Intraoperative signs of perforation. Reduced sight reflex due to vitreous hemorrhage. Serious sight-threatening vitreoretinal complications may result. Seek the advice of a specialist vitreoretinal surgeon. Number 3. Nerve injury. Optic nerve may be damaged by direct trauma by needle, ischemic damage from intra-sheath injection or hemorrhage, pressure from retrobulbar hemorrhage, pressure from excess local anesthetic injection into the retrobulbar space, excessive applied external pressure. Need to care. Avoiding deep injections into the orbit. Injecting with the eye in the primary position. Number 4. Brainstem anesthesia. Due to spread of local anesthetic along the optic nerve sheath. Post-retrobulbar block apnea syndrome is probably due to injection of local anesthetic into the optic nerve sheath with spread into the cerebrospinal fluid. Symptoms and signs. Drowsiness, lightheadedness, confusion, loss of verbal contact, cranial nerve palsies, convulsions, respiratory depression or respiratory arrest, cardiac arrest, onset of symptoms within 10 to 20 minutes of local anesthetic injection. Symptoms lasts 4 hours. Number 5. Muscle palsy. Diplopia and ptosis are common for 24 to 48 hours post-operatively when large volumes of long-acting local anesthetics are used. If this persists or fails to recover, it may be due to muscle damage as a result of intramuscular injection of local anesthetics, local anesthetic myotoxicity, ischemic contracture following hemorrhage or trauma, avoidance of regional complications, clear knowledge of orbital anatomy and individual variation, clear knowledge of ocular anatomy, individual variation, individual patient's ocular history, for example, extreme myopia, multiple eye surgeries, training, supervision, practice under qualified instructor, appropriate peri-block sedation, full basic monitoring, availability of emergency equipment and medication, take-home messages. All local anesthetics agents are myotoxic. Direct injection into a muscle should be avoided. No local anesthetic technique is entirely free of severe systemic adverse events. Short, fine needle should be used. The eye in the primary gaze position looking straight ahead. Gentle aspiration after insertion of needle should be done to alleviate possible entry to blood vessel. Bevel of the needle facing the globe and tangential to sclera. All ocular surgery with local anesthesia should be treated as GA. That brings us to the end of today's lecture on anesthesia for ophthalmic surgery. If you found this video helpful, please like, share, and subscribe to SAK Anesthesia for more anesthesia-related content. Thank you for watching. Learn anesthesia, practice safely.